The interventricular septum divides the ventricular chamber into right and left ventricles. It consists of two parts, that is the muscular part and the membranous part. Muscular part comprising the majority of the septum is present inferior to the membranous part and it is thick. It is derived from the bulboventricular flange. And the membranous part, which comprises the minor portion of the septum, is present superior to the muscular part and is thin. It is derived from the neural crest cells. In this picture, this is the muscular part of the interventricular septum, and the superior one is the membranous portion of the interventricular septum. Any part of the interventricular septum can develop a rupture. The size of the rupture determines the prognosis of the patient, and the prognosis is good if the rupture is small and the patient is hemodynamically stable. Etiology. The most common cause of ventricular septal rupture is full thickness, that is transmural myocardial infarction in one of the following coronary arteries: left anterior descending coronary artery that supplies most of the anterior portion of the interventricular septum. It can lead to apical VSR. And the dominant right coronary artery that supplies the most inferior portion of the interventricular septum. This can lead to a basal VSR. The dominant left circumflex artery supplies the posterior portion of the posterior descending artery and arises from the circumflex branch. The partial thickness infarcts such as non-ST elevation myocardial infarction or unstable angina can also increase the risk of ventricular septal rupture. This picture depicts a transmural myocardial infarct. It is a transverse section of the left ventricle. The blue color part depicts a normal myocardium, and the pale yellow color tissue is the infarcted area, which is in the anterior and the septal portion. Pathophysiology. The blood flow to the septum is derived from the branches of the left anterior descending coronary artery and the posterior descending coronary artery. In rare cases, it is also supplied by the circumflex artery. The infarct is usually transmural and extensive. Nearly 2/3 of VSR occur in the anterior septal wall and about 1/3 occur in the inferior or posterior wall. When the latter is involved, it is often accompanied by mitral valve insufficiency secondary to papillary muscle dysfunction or rupture. At autopsy, the culprit coronary artery is almost completely occluded with the absence of collaterals. In rare cases, there may be multiple septal perforations. The primary mechanism behind the ventricular septum rupture is physical shear stressors, especially at the junction of infarct area and the normal healthy myocardium. Due to this mechanism, ventricular aneurysm, free wall rupture, or papillary muscle rupture are associated with ventricular septum rupture. Cardiac free wall rupture and ventricular septum rupture after myocardial infarction are similar regarding the pathological characteristics. There is a pathological classification regarding free wall rupture, which we can use for ventricular septum rupture as proposed by Becker. There are three types. The type 1 is sudden in onset, slit-like tear, which occurs within 24 hours. And type 2 is subacute, erosion of the infarcted myocardium. And type 3 is a late presentation, aneurysm formation, rupture associated with older infarcts. After establishing a new connection between the right and left ventricle due to the ventricular septal rupture, oxygenated blood shunts from high pressure left ventricle to the low pressure right ventricle. Risk factors: female gender, increased age, first episode of myocardial infarction, because the previous ischemia induces myocardial preconditioning, decreasing the likelihood of transmural myocardial necrosis and septal rupture, and hence patients with evidence of diabetes mellitus, chronic angina, or previous MI are less likely to experience a rupture. ST segment elevation myocardial infarction, hypertension, and chronic kidney disease. Presentation: the patient may present with flash pulmonary edema after 1 to 3 days following a stable MI. Severe cases present with cardiogenic shock. Auscultation will reveal a loud systolic murmur following an MI. This feature is universally heard in most cases of VSR. The murmur is heard usually over the entire precordium. One may also feel a thrill in some patients. In patients with a large VSR and severe heart failure or cardiogenic shock, the murmur may be of low intensity or inaudible, but the absence of a murmur does not rule out VSR. Due to increased right heart flow, sometimes there is a loud pulmonic component of the second heart sound, tricuspid regurgitation, or third heart zone. Almost all patients complain of recurrent chest discomfort. At the onset of murmur, the patient may have a sudden change in hemodynamics. Evaluation. Chest X-ray may reveal left ventricular enlargement and florid pulmonary edema findings. ECG establishes the diagnosis of STEMI. In case of post-MI VSR, it may show atrioventricular or infranodal conduction abnormalities in approximately 40% of patients. Transthoracic echocardiography and Doppler. It is the test of choice of diagnosis of VSR. Echocardiography helps in determining the size and site of rupture and the magnitude of left to right shunt. Basal VSR is best visualized in the parasternal long axis with medial angulation, the apical long axis, and the subcostal long axis. Apical VSR is best visualized in the apical four-chamber view. Echocardiography also provides insight into the feasibility of using percutaneous closure devices in this setting. The assessment of ventricular function is key to the prognostication and management as they remain important determinants of mortality. This is a post-infarction echocardiography showing the anterior apical VSR. And this is the apical four-chamber view showing a VSR. Right heart catheterization, pulmonary artery catheterization with oximetry measurement can help diagnose VSR by showing an oxygen saturation step up in the right ventricle and pulmonary artery. This is helpful in differentiation from post-MI acute mitral regurgitation in which the step up is absent. It is only undertaken in stable patients. Other investigations which can be performed in hemodynamically stable patients include cardiac MRI or left heart catheterization. Ventriculography performed after angiography may reveal VSR if it is highly suspected. The ultimate treatment of ventricular septal rupture is a surgical repair. Before surgical repair, it is necessary to restore the circulation in the diseased artery to decrease the hypoxic burden in the infarcted area, especially in cases of right ventricular involvement. Principles of medical management of VSR. Hemodynamically, the occurrence of VSR gives rise to left to right shunt and reduces forward blood flow. Compensatory increase in systemic vascular resistance, thus the LV afterload, leads to an even more rigorous left to right shunt. The management should be directed at reducing the vicious left to right shunt with afterload reducing pharmacological agents and mechanical circulatory supports. Inotropes and vasopressors may worsen left to right shunting, whereas vasodilators decrease shunting at the expense of hypotension. If pharmacological therapy is not tolerated or if it fails to achieve hemodynamic stability, intra-aortic balloon pump should be considered. IABP in VSR management. Several studies have demonstrated IABP's beneficial hemodynamic effects in post-MI VSR. Its application results in a significant reduction in left to right shunt volume and shunt flow ratio with a concomitant increase in the effective systemic cardiac output. These outcomes are mainly achieved from the afterload reduction. IABP also increases coronary perfusion and decreases myocardial oxygen consumption. Both effects results in the amelioration of myocardial ischemia. IABP support in shock caused by post-MI mechanical complications, primarily due to VSR, significantly reduces preoperative mortality. Surgery could be delayed for an average of 9 days from acute VSR onset using IABP or respiratory management without deterioration of organ function. The strategy was also associated with favorable 30-day mortality and long-term outcome. However, IABP hemodynamic support is often insufficient in more critical patients, and combination with other mechanical circulatory supports like ECMO may be beneficial. Surgical management. Current guidelines suggest that as soon as the patient is stable, surgery should be performed. Surgery should only be delayed in following cases: when there is no evidence of cardiogenic shock, patient having good perfusion and cardiac output, minimal or no signs of congestive heart failure, minimal use of vasopressors, no retention of fluid, normal kidney function. Some studies suggest surgery may be delayed to allow healing of friable tissue and improve surgical mortality. Among medically treated patients with VSR, the mortality is 24% at 72 hours and increases to 75% at 3 weeks. The surgical mortality is high among patients with inferior MI, that is 70%, when compared to patients with the anterior infarcts, which is 30%. This is because of the greater technical difficulty and the need for concomitant mitral valve repair in patients with basal septal rupture, since they often have coexisting mitral regurgitation. The repair of a posterior ventricular septal rupture is more challenging than an anterior rupture due to the proximity of the papillary muscles. If the ventricular septal rupture develops within 24 hours of an MI, surgical intervention is more difficult as it is difficult to differentiate between the healthy and newly infarcted tissue. Also, at this point, the muscle is weak and not be able to hold the sutures. Additional procedures that may be required during the report of a VSR include mitral valve replacement, coronary artery bypass, and resection of the left ventricular aneurysm. Timing of surgery. Current European Society of Cardiology guidelines recommend that the patients who respond well to aggressive heart failure treatment and are hemodynamically stable are good candidates for an elective delayed surgical repair due to the high mortality described in the first 24 hours of surgery. Many studies reported that the operative mortality is 54% if the surgery is performed within 7 days compared to 18.4% when it is performed after 7 days of VSR diagnosis. This timeline allows a scar formation which helps in holding of the sutures. However, when the patient is hemodynamically unstable, there is a need for urgent surgical repair even with high operative mortality. Surgical techniques. The traditional surgical treatment for post-infarct VSRs had been the performance of a ventriculotomy through the infarcted zone, resection of the area of the septal necrosis, and Teflon felt or pericardial patching of the septum and free wall. This technique required transmural suturing and was prone to recurrence. The preferred approach is to perform circumferential pericardial patching around the border of the infarcted ventricular muscle. This technique excludes the infarcted septum to eliminate the shunt and reduces recurrence rates because suturing is performed to the viable myocardium away from the area of necrosis. Coronary bypass grafting of critically diseased vessels should be performed. Early studies suggested this improved short-term and long-term survival after surgery. The above picture shows an anterior VSR and the below is inferior VSR. Pericardial patch is anchored to the viable myocardium away from the site of the defect, thus eliminating the shunt flow across the septal defect. This is a VSR closure with the polytetrafluoroethylene patch. Consideration may be given to percutaneous VSR closure with the Amplantisar VSD closure device in patients with smaller VSRs or prohibitive surgical risks. Thank you, sir.
Okay, it was a concise presentation, but there are a lot of things that you didn't touch upon and highlighted upon during the management of this important complication of an MI. A post-infarct VSD and a post-infarct ischemic MR are something that every cardiac surgeon should know. Now, the first thing that is there is the diagnosis of the post-infarct VSR, and that is generally done by a transthoracic echo, occasionally, maybe if necessary, by a TEE. Cardiac catheterization is generally not resorted to many a time. MRI can give us better information nowadays with the newer Tesla machines, but it takes time. So if the patient is stable only, then you can take him down for an MR, and then because it takes almost 45 minutes to do an MR. The most important thing that you have to know is the site and the size of the VSD. So you said small VSD, large VSD, that doesn't mean anything. There has to be definitive things, and surgical management is the bottom line for all these patients. However, if it is small, as you said, small means it may be 2 mm, 3 mm, or less than 5 mm, then you can wait, and if the shunt is not so severe, you can wait till the tissues around become a little more fibrotic to hold sutures, as you said before. The timing of operation you mentioned, yes, the later the way you can do this thing is better, because the tissues are much more amenable for suturing and holding the patch in place. Now, in medical treatment, you should have talked about a little more about the pros and cons. When do you use medical treatment? When do you change over from medical treatment to surgical management? And medical, remember all these things: medical management, vasodilators, IABP, are all temporary procedures and not curative. So it is only to buy time. So you must understand that basic principle.
Yes,
The
sir.
type of operation, you didn't mention anything about the type of operation, how you will go in, what is the approach. Generally, you said post infarct, but then most of the time when we have a VSR, we go through the para coronary area around the infarct through the LV side, unlike the congenital VSD. So LV side, and then you put a wide patch, and then you also have to do. Sometimes you may also need to, or probably inadvertently also, you may occlude the LAD. If the LED is already blocked, then it is okay. But if it is LED is not blocked, then that causes another problem. So that comes to the question of, should all these BSD patients have a LED coronary graft? So that you didn't mention about it. Approach is important, and post-op management complications. Then of course, they, most of them are very sick patients, and they go into low cardiac output syndrome, and then prolonged ICU stay, ventilation, and all those other things are a problem. And you also should mention what happens to these patients in the long term effects. I'm sure there are many articles which have done some follow up studies, and then what happens to them in the long term. And finally, as we have already always said, what is our own experience? What is NH experience? Yeah.
Yes, sir.
So these are the few things that you should have highlighted upon, because these are the practical things which you have to take a decision when you see a patient with VSR in the ward. Anything to add, sir?
No, it's a good presentation, but few things I will have to add. From literature, it is well known that the complications of acute myocardial infarction may be a VSR, mitral regurgitation, and maybe later on or in the same period, free wall rupture of the left ventricle and delayed like a left ventricular aneurysm. These are the classical combinations. In that, the most critical ones are acute rupture. And actually, your PEC classification is actually for free rupture of the left ventricle. And you said now that's extended to the classification of Beck 1, 2, and 3 for VSR also. And classically, we used to teach that the incidence of acute VSR is about 1 to 2%. This has been reduced in advanced countries to 0.3%, mainly because of the thrombolytic therapy, which is instituted early in the golden hour or within 4 hours, that markedly reduces the incidence of ventricular septal rupture. And the most important lethal factors are, you mentioned that when there is a cardiogenic shock, when there is acute MR is more common in a posterior VSD because that's close to the posterior papillary muscle and can cause rupture of the posterior papillary muscle itself or infarction of the base of the posterior papillary muscle, which causes dysfunction of the posterior papillary muscle. And the other complications, pulmonary edema, increased pulmonary venous hypertension, and fluid retention, and renal failure. You mentioned all these complications which can lead to increased mortality. And generally, they say the anterior or anteroapical because of the LAD, and that constitutes about 60% of the VSR, and about 40% are inferior and posterior. That's because of the right convolution. And you mentioned the medical treatment. The classical thing is reduce the afterload, and that's all you mentioned, the diuretics. And then most important thing is a mechanical circulatory assist, like IABP. So that gives you more time. Untreated, they say the mortality within 24 hours is 25%. Within 7 days, it's about 50%. Within 2 weeks, it is about 70%. The chance of survival is much less. And you mentioned the surgical technique, but you didn't mention the historical surgical techniques, because historically, it's always approached through the infarct itself, left ventricular incision infarct, and it's very often divided, and necrotic muscle stops and whether the viable septal myocardium is there. But the basic principle is cut off as much as the infarcted muscle. And traditionally, the approach used to be a single patch, a two-patch technique, and now the pericardial patch technique only on one side. The single patch technique originally we used to do in the 1970s is approach through the infarct, do resection of the infarcted part, and then put pledgeted non-absorbable pure mercury-like sutures with a pledget through the VSC from the right ventricular aspect, put multiple of these interrupted pledgeted sutures from the right ventricular aspect to the VSD, and then bring them onto the left ventricular aspect and put a patch on the left ventricular aspect. That's the single original, historically, the single patch technique. Then became the double patch technique. That means you take a patch little bigger than the VSD, take unpledgeted sutures, not at the edges, but little away from the edges, and pull the patch into the right ventricle, and then take all the needles through the margins of the VSD. So all the sutures now come onto the left ventricular aspect, and put another patch through which all these needles are passed, and tie them so that the ruptured ventricular septum is now between the two patches. Used to be dacron, later on cortex. That also nowadays, as you said, very often nowadays what we do is very large pericardial patch, much larger than the VSD, so that you can suture them directly to the viable myocardium. That's a single pericardial patch. And the mortality of anterior VSD nowadays is at 10 to 15%, or posterior is about 30 to 35%. And I remember many years in 1970s in Sydney, we conducted a study of results operated before for 3 weeks, after 4 weeks. Nowadays, it's study between the first week and second week. And you mentioned that there's a marked difference in the mortality between the after 7 days and before 7 days. In the Sydney study, after 3 weeks, we found the mortality the results are much better now because they've got mechanical circulatory assist device, and then you should have mentioned something more about because most of the cardiologists are now very keen to do a cath closure of the ventricular septal defect. Some of them, especially the anterior VSDs, are suitable for a cath closure. And actually, one literature I saw yesterday, they claim 89% success for a cath closure, and the device used like an emplaster device. And then I read that it depends on the size of the emplaster device you use. If it is less than 24 millimeter waist and the flanges are slightly higher, only about 50% of the VSDs will be closed. So they suggested larger emplaster devices, The currently used emplaster devices, I don't know, it's made by St. Jude, I think. So, and they said last CAT 89% successful and 32% in hospital mortality. Isn't that the only thing commentary that you should have mentioned something about the historical type of closure of a single patch, double patch, and of course, a cat closure that is now done in many cases, but it has to be on selected case. Any other question or comments? And then you should have mentioned something. What is our statistics? We do a lot of cases, and what approach we do. And of course, Shekar and I have been telling cat closure. How many cat closure? I think we have done a few cat. What's the result of that? At least those things. In an exam, they might ask you, what's the experience in your hospital? What's the procedure done in our hospital?
Will you find out about it, Kavya? Can you walk into the cath
Yes.
lab and get their statistics as well as surgical statistics, and so that we have an idea what's happening?
Yes, sir.
And what happens before 7 days and after 7? How we can postpone the operation till after 7 days because of mechanical circulatory accident and the afterload reduction treatment. And these things are important, when to do the operation. Have you seen one?
No, sir.
I'm sure we have done a number
not
of them.
You've done a lot. I remember Venkat used to come and tell me a lot of cases.
And you should have gone into a little bit of the literature survey and then see what are the long-term results, what happens to these patients. That's also an important thing to know.
Yes, sir.
So our own experience and what are the general experience from others in the long term this thing. Of course, we don't have that sort of follow up for our own long term things, but at least there must be something in the literature.
Yes.
Okay. Any other questions? You didn't invite any consultants today. You know, Rahul and the younger fellows, Rahul, Sundar, and all can take part if they are free.
Yes, sir.
Gagan is there. Then we have so many fellows. All the fellows who have just passed. It's okay if they are doing pediatric or minimal invasive fellowship, but this is all normal general cardiac surgery. They could take part.
Okay, sir.
I think you should inform all of them. You know, at least the junior consultants can join if the senior consultants are all very busy.
Okay, sir.
Okay. Thank you, sir.
Thank you very much.
Thank you, sir.
Okay, thanks, Kavi.
Thanks.